Kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow Unit, and it's my great pleasure tonight to introduce Dr. Hannah Giles. She's a New Zealand-trained gastroenterologist and hepatologist. She currently works at the as a transplant hepatologist at the New Zealand Liver Transplant Unit. She also does some private practice at McMurray Specialist Centre, doing upper GI endoscopy, gastroenterology, and hepatology. She recently returned from working as a consultant in Addenbrooke's in Cambridge, UK. She has a special interest in immune-mediated liver disease, nutritional management of liver and gut disease, and mast cell MCAS activation syndrome. She has a large portfolio in research in hepatology and mast cell disorders. So welcome, Hannah. Over to you.
So what I'm going to talk to you today is a little bit about abnormal liver function tests, which I'm sure is something that you dread finding in your practice. And then I want to talk about reversing metabolic liver disease, as reversing disease is something that I'm very passionate about. Okay, so this is a case that was referred to me, and I don't normally get a case like this. This is a really good one, as I feel this is the type of case that you would be seeing very, very commonly. This patient is only 35 years old, a Filipino gentleman. Past medical history is already quite long, but I have to say very thorough GP who's already done all of these things. They're all quite early. So BMI was 38, high blood pressure, dyslipidemia, pre-diabetes, OSA, and eczema. So as you can see, for a 35-year-old, he's already compiling quite a significant metabolic history there. So he's already as well on 3 medications, which I'd say is not necessarily normal for a 35-year-old. So he's on atorvastatin, losartan, and candesartan. Social history, relatively unremarkable, lives with his wife and 2 children. He's an ex-chef. He now works for the Ministry of Defence. He drinks no alcohol at all. He's very fit and well. Previously did no exercise, but recently, after advice from his doctor, he started running and walking 3 to 5 kilometres 4 times a week. So these were the blood tests, and this has been over the course of a few years. He's had a relatively elevated GGT, elevated ALT, and a mildly elevated urate, as you can see. And this is at the point that he was referred to us. So the other tests showed a mildly positive ANA and a mildly positive IgG, which is why he got through to our service, and a mildly elevated HbA1c, but a negative liver autoimmune antibody screen. So an ultrasound, as would routinely be done, so anyone with abnormal liver function test should have an ultrasound as per routine. What this is most likely going to show is just steatosis, meaning fat in the liver and a bright liver. But the important things that you want to rule out is obviously stones, so cholelithiasis or choledocholithiasis, and focal liver lesions and biliary obstruction. So, you know, the focal liver lesions are often just picked up very sporadically, but it's important to do an ultrasound just in case. So the differential diagnoses in this chap, I think with his long list of existing medical problems, I think you're going to put metabolic liver disease at the top, but you always need to consider other things. So alcohol is obviously very common, but we know this man doesn't drink. Medications is also another strong possibility, and I think about that with all abnormal liver tests. Although his liver tests have been very static and stable for some years, so I suspect it's not medications. Autoimmune hepatitis, I think in this gentleman is very unlikely. So I think the mildly positive ANA and IgG is probably not significant. The liver tests are not really high enough to consider autoimmune hepatitis. And autoimmune hepatitis is not associated with a steatotic or fatty looking liver on ultrasound scan. So other liver conditions, I think in this gentleman are even less likely. So Wilson's, which is copper storage disorder, and hemochromatosis, which is an iron storage disorder. These disorders actually can have a fatty looking liver on ultrasound scan. But I think, again, in this gentleman, you know, it's most likely going to be metabolic liver disease. It's unlikely to be something else. So drugs. I think a large number of my referrals with deranged LFTs, crude cause, actually end up being medications. Can be prescribed, can be non-prescribed medications. So It's also interesting to note that some medications can also cause steatosis. They can cause fat to go into the liver. Some of that's through kind of a drug-induced liver injury or other mechanisms. But classic medications that can cause fat to go into the liver are things like SSRIs, epilim, estrogens, steroids. There's all sorts of medications that can actually cause essentially fat to go into the liver. But also when you have a fatty liver is more sensitive, and a fatty liver will react to a lot more drugs. So if you have a baseline of fatty liver and then you give that patient antibiotics or anti-inflammatories, then they're actually more likely to then have an increase in their liver tests in association with that. It's not necessarily a big problem, but I think just something to be aware of, that you need to have a really close review of the medications and think about a trial of withdrawal, if appropriate. So what to do next? So in any patient where you think you have metabolic associated liver disease, so you do your basic liver screen, ruling out things like viral hepatitis, autoimmune hepatitis. You've done your ultrasound scan to rule out your liver lesions and your cholelithiasis, and then you need to get out your med calc. My favorite, I was Google med calc and look up the FIB4 score. So the FIB4 score is essentially how we triage patients as to whether they will be able to come, whether they need to come to secondary care or whether they should be looked after in primary care. And the FIB4 is very good at excluding significant fibrosis. So in this patient, so the main thing to remember is to get an AST when you request liver tests, otherwise you can't calculate your FIB4 score. So you need your age, your AST and your ALT and your platelet count. Calculate, nice and simple. And this patient has a FIB4 score of 0.36, which essentially excludes advanced fibrosis. So if it wasn't for the ANA and IgG, this patient would have stayed in primary care. Now, the most exciting thing to report that already by the time he saw me, he had had advice from his GP about changing his diet, changing his lifestyle, and he had decided to try prolonged fasting and started daily exercising. So I thought that was cause for celebration. So other things to think about. So if this had been a more short-lived or more significant derangement in the LFTs, then I would have paused the atorvastatin. And if you pause it and it gets better, then it was the statin, and you can consider trying other statins. And again, any other herbal or alternative or NSAIDs or any other medications you think might be causing it, pause it for a few weeks, follow up the liver test and see if it gets better. And then that's diagnostic that was the cause. So what else can we do? So the dreaded conversation. I think this is where people feel very helpless. So just diagnosing someone with metabolic associated liver disease and telling them to go away and lose 10% of their body weight, or telling them to exercise more, unfortunately, is probably what patients feel like is a stuck record. So most patients know that they need to lose weight, but they don't like being told that they need to lose weight. But part of the problem is also that they don't know how to lose weight. They don't know how to change what they're doing. So this is the most important thing that I learned. So when I was a registrar at the liver transplant unit, we had some wonderful dietitians who were not actually funded to help patients with metabolic diseases, but they did it anyway. And they taught me how to do a really good diet history and then how to treat those patients. And over the years, I always take that bit of extra time to do a diet history with my patients, but it always pays dividends. And now that I've got used to it, I've realized actually how many of patients' problems come down to how they're eating and what they're eating. And it's quite fascinating when you start doing this regularly. And sometimes also we can have a good laugh about it with the patients when they realize how ridiculous it is drinking 2 liters of Coca-Cola in a day, or drinking, 10 smoothies in a day, and that these things are probably contributing to their problems. So how I open it is I say, okay, just tell me what you eat on a normal day. Start from when you wake up in the morning, and then we'll go through. So I say, tell me what you have for breakfast. Write it down. And then I ask them about morning tea, thinking in my head, adults probably don't need snacks, but anyway, everyone does. So what do you have for breakfast? I'll ask, are you having any drinks for that? Anything else? What are you having for morning tea? What are you having for lunch? What are you having for afternoon tea? What are you having for dinner? Do you have any pudding? And then specific things that I always ask about is fruit juice, fizzy drinks, squash, and smoothies, because these are all very high calorie and people do not realize that these are very high calorie. So very important. And then treat foods, biscuits, crisps, desserts, ice creams, takeaways. How often are you eating takeaways? And then by the time I've finished taking that history, I normally have a really good idea of what is going on. And I then spend some time. So before I start to go in telling them what I want them to do, I spend some time kind of, I guess, taking a step back and explaining to them that there's no judgment here, and explaining that essentially there's been a huge cultural shift in terms of how we eat, the food availability, the type of food that is available, to the point that people feel that it is normal to eat everything from a packet. It's almost become abnormal to prepare things from raw ingredients and eat that, or to eat raw ingredients. So people feel more comfortable getting packet food and pre-made food without realizing, that the commercialization of the food industry is actually hurting their health, essentially. And it's not just that, it's also about the proportions of food. People have all these images of essentially carbohydrate, fat, sugar-rich foods in their heads. That's what's portrayed in the media, and that's what people believe is a normal way to eat. And so I try to spend some time talking about this distorted idea of what normal eating is, and talking about what our grandparents would have eaten in the 1950s is completely different. And how it's really just commercialization of the food industry that has kind of changed how we perceive what is a normal meal. And then I start to explain about how all these highly processed foods cause big highs and lows in blood sugars and insulin. I'll show you a graph in a minute. And then I explain to patient that's why you feel hungry all the time. So even though you may not be eating a large volume of food, you're getting a big sugar rush, then you're getting a big spike in insulin, then you're getting a big sugar crash, and then you need to eat again. This is why you never feel satisfied, and you constantly feel hungry, and you feel like you have no energy. So all this food is actually making you feel unwell. So if we look at the data to try to back up what I'm saying, essentially this looks at the proportion of ultra processed foods in an adult's diet. So ultra processed foods is foods that contain additives that you would not have in your kitchen, essentially from flavorings, preservatives, colorings, numbers, all that kind of thing. So if we have a look over here, I've got my face in the way, can't see. So the UK and USA are around, between 50 and 60% ultra processed foods in their diet, and Australia is around 42. I mean, I'm sure we're going to be around here in a similar position. So, it's quite frightening to think that people are eating 40 to 50% of their diet is ultra processed foods. Okay, and there's lots of adverse health outcomes associated with ultra processed foods, as you can imagine, cardiometabolic, psychiatric disorders, and also all-cause mortality is generally higher. So I explained that this is a vicious cycle, and I often draw this wiggly line on a piece of paper. I say, okay, when you eat your, your pasta with some sauce, just a bowl of pasta, your blood sugar goes up. You feel full for about an hour or so. Then your body reacts and panics because your blood sugar is too high, causes a big spike in insulin, and then you get an overcorrection and a low blood sugar. And this goes on throughout the day. Whereas if you eat things that are lower GI, so I explain what is low GI, so, lean proteins, fibers, whole grains, then you don't get that big spike, you don't get that big a lot of insulin, and then your blood sugars can stay stable throughout the day, so you feel satisfied, you get less of that hunger starvation cycle. So the other thing to remember is that metabolic liver disease is really a symptom of a systemic disorder. So it's not a disorder in isolation. It's a disorder of the whole body, and it's strongly associated with all the other metabolic disorders, including cardiovascular disease, kidney disease, polycystic ovaries, OSA, obesity, and type 2 diabetes. So it's not a disorder on its own. So then I try to go to the motivation side of things. And I say to the patient, would you prefer that I prescribed you 5 medications? So we can look at prescribing 5 medications to treat all the symptoms of this disorder. So I can treat your high urate, I can treat your high cholesterol, we can treat your high blood pressure, we can give you some aspirin. Or would you like to try to focus on treating the underlying cause of this problem? And to me, this is the most satisfying part of my job. If I can get someone to do this, then you can actually cure somebody. So this to me is, the exciting part of this. And if you do this conversation again and again and again, you will get to that point where you really can get that change. And kind of working out what things you can say and obviously reading the room. And I explained that this is a warning. So this is a symptom that you're at risk of things in the future, like worsening diabetes, cholesterol, heart disease, strokes. It's a symptom that your body is not happy with your current weight. So instead of me saying that I'm not happy, I say your body is saying that it's not happy with your weight. You can control the future of your health. When you reach a weight that your body is happy with, your liver tests will normalize, and this is all reversible. So then we do a BMI calculator, but I may or may not do this on the first appointment, really depending on how fragile the patient seems. If the patient seems very fragile, we won't do this. If they need more convincing that they're a long way away from where they should be, then I might do this. So I'll show them, what weight would give them a normal BMI and what their current BMI is. They can see the difference in the weight. It's usually quite large. So I'd only do this if I thought that they could handle it at that time. So then I go and spend some more time in the education, discuss how we don't actually need snack foods, and explaining that most snack foods and snack bars are actually equate to a meal in terms of energy content. And if they need a snack, it should be fruit or a handful of nuts. I try to get patients to stop all fruit juice, fizzy drink, energy drink, squash, and essentially go to, coffee with no sugar and water. Zero sugar drinks are also, there's some evidence coming out about zero sugar drinks causing changes in things like insulin, affecting hunger, and actually potentially are just as bad as the drinks that contain sugar. So I do not suggest changing over to zero sugar drinks. And I ask them to change to a more of a whole food diet. And then we start talking about exactly how to do it. Sorry. So this is the model that I've been using since 2014. It's really simple. And I think if you have a little bit of knowledge around the different types of diets that are eaten by different cultures, it's very easy to adapt to each different culture. Because you can just tell a patient that you get your plate, a normal size plate, so a 1950 size plate, not a 24 size plate, and then I cut it into 4. And then I'm going to show you how we portion it. But essentially they need to have a quarter of lean protein. And then I ask the patient, what is a lean protein? Can you give me an example? Usually they can't. And then I talk about, chicken breast with no skin or batter, white fish with no skin or batter, as opposed to things like sausages, bacon, etc. And then talk about half your plate should be non-starchy vegetables or salad, and a quarter of your plate can be your carbohydrates. And then we'll talk about portioning in again in a minute. But again, it's about trying to understand what food you can eat that make you put on weight and what food you can eat more of without putting on weight. So I explain to them you can eat as much lean protein and non-starchy vegetables as you want, and it will not affect your weight and it will make you feel full. And all you need to do is control your carbohydrates and avoid too much of the high fat, high sugar, snacky foods. So I'll talk about, I mentioned it earlier, the distorted images of normal. So this kind of meal here, this pasta meal that is, more than 90% carbohydrates with almost no protein would be perceived to be a normal meal. And it's important for people to understand the proportions of what they're eating. This meal down here would actually meet the right kind of balance criteria. But this is the type of meals, obviously cost, I know, is a big issue. But there's ways to work around it, but this type of meal, unfortunately, is going to make people hungry and put on weight, and it's not going to meet all their nutritional requirements. So this is how we do portioning. And I love this bit. I always put my fist and I ask the patient to show me their fist. And then I put their fist next to my fist, and usually their fist is a lot bigger than mine. And I say that, well, your fist is designed for you. That's unique for your body. My fist is designed for me. So your fist is a quarter of your plate. So when you make your plate up at night, you can have a fist of lean protein, a fist of carbohydrates, and 2 fists of non-starchy veggies or salad. And when you get to the weight you want, you can increase your carbohydrate portion. If you want to put on weight, have 2 or 3 fists of carbohydrates. If you want to lose weight, you need 1 fist of carbohydrates. So eating this way helps to keep your blood sugar stable, stops big dips, which cause low energy and snacking. But I warn people to give it 6 weeks to allow them to detox, because there is this addictive nature for the high sugar, high fat, high carb diet. And they'll be used to that feeling of being very overfull when you eat a lot of carbohydrates, fat, and sugar. So it's a changing to feeling satisfied but not overly full, and getting used to having those lower GI meals. So it's a bit of a detox, but if you warn them it's going to be about 6 weeks, then they will kind of be prepared for that mentally. So the goal, which doesn't overface anyone, is I always say 1 kg per month weight loss. And so when you say that, people just relax. It's not a big deal. So you're not talking about needing to lose 20 kilos, 30 kilos, 40 kilos. It's realistic. And all you're asking them to do is not restrict what they're eating. You're asking them to change what they eat and how they eat. And that way they will actually naturally lose weight. So just by cutting out those ultra-processed, high sugar, high fat, high carb foods, reducing the carbs, and having more lean proteins and fiber, they will actually lose weight. And so you're saying slow and steady, aiming for a normal BMI, probably over a period of years. So we're looking for sustainable changes, not starvation. And you can still have treats, but not every day, because if it's every day, then it's not a treat, it's your regular diet. So you can have your takeaway once a week, you can have some chocolate once a week, some biscuits once a week, but not every day. So it's very hard to prove that anything is effective in weight loss, but there is some loose evidence that portion control plates do essentially work. They looked at 22 intervention studies using the portion control plates in nutrition interventions, and these appear to promote weight loss amongst those with overweight and obesity and or type 2 diabetes, although acknowledging they were mostly used as part of multi-component interventions. So this was this patient again. So his progress was, he'd recently significantly cut down. So he was trying to skip lunch, skip breakfast, skip lunch. He was having coffee, banana bread, and peanut butter when he got back from work, which is probably not ideal. And for dinner, he was having 2 cups of rice with protein and vegetables. So, but, even though it wasn't perfect what he's done, he's reduced his weight by 4 kilos already. So he did this on his own after talking to his primary care physician, and he's already had some success. So we just talked about tweaking it to make it more sustainable, because not eating all day is not necessarily something he can continue to do. And he needs to understand that bananas are high in carbs, bread is high in carbs, and peanut butter is high in fat. So they're probably not the ideal things to be eating. So these were his blood tests. So I was pretty happy. So this was at the point of referral, and this was after the intervention from his GP, where he started exercising, changed his diet, and lost 4 kilos. As you can see, this again proves that he has metabolic liver disease, and it's gone down from 120 to 67, and his ALT has gone down from 75 to 45. And this to me is the greatest satisfaction. So if you see this happen, you know that you are able to cure this patient and also give that patient control over their lives. This is not their destiny to have extensive metabolic diseases. This is actually manageable. So he had a fibro scan as well to be complete, showing no fibrosis, but he still had significant steatosis. So even with the improvement of his liver test, he's quite a bit away from getting all that fat out of his liver. And we know he still has some weight to lose. So plan from there, I congratulated him on his progress. I said, that's amazing. We talked about tweaking him over to the healthy plate model, which I thought was more sustainable. Gave him the education around food types. Based on his cultural background, we talked about the different types of foods he could use for his healthy plate model. We set short and long-term targets again, the kind of 1 kilo per month, and then long-term trying to achieve a normal BMI within a couple of years. And then I discharged him back to primary care for ongoing support and monitoring, and with a plan for coming back for, he'll need a repeat FIB-4 in primary care in 2 years. If that at any time becomes elevated, then he can come back for another fibro scan. But if everything continues to improve, then he won't need to come back. So in summary, if you identify a patient with metabolic associated liver disease and associated metabolic risk factors, my suggestion, so I always run over time when I have these patients, but my suggestion would be that to book them to come back, give yourself at least 20 minutes, if not longer. So, identify people, if everyone or certain people in your practice, if you want to have a nurse specializing in this area, could you have a dietitian visiting? Do you yourself want to do it? And upskill in this area around how to take a diet history and how to educate people around the healthy plate model and how to get your pitta-patta around, getting that engagement from the patients. And it's all about making it unique to that patient and relevant to that patient and easy. and setting their goals. So, do the diet history, give them their interventions, set their goals. And then what I think you should ideally do is be repeating the markers every kind of 3 to 6 months, because that provides the positive feedback to the patient. So if their particular problems are hyperlipidemia, high blood pressure, HbA1c, liver test, then those things can be rechecked every 3 months. And the patient then has more positive feedback that the changes that they're making is actually having a huge impact on their body. And then you can give the feedback at the same time to say that that's amazing, keep going, what you're doing is working. And then at the same time, that whether it's the nurse in the practice or the general practitioner sees them, they can then go and tweak the diet. So I always find it takes at least, say, a couple of follow-ups where you go back over what they're eating just to come up with some tweaks, because there'll be some things that's not quite right. But then, the education is finished. They understand, they know how to control it. So in summary, anyone with metabolic liver disease can be considered, but in primary care, it's really focusing on those F0 to F3s, the ones that don't need to come in and be managed for cirrhosis, because they're the ones that are fully reversible. So even if they get to stage 3 fibrosis, that is fully reversible if the fat comes out of the liver, which is what's so exciting. So obviously you need to treat the metabolic associated complications. However, as the patients improve, review those medications, reduce the doses, stop the medications if they're improving. Again, it gives them more positive feedback. If they have risk of significant fibrosis, then you need to refer them as per health pathways. And yes, there are more sexy drugs coming. I'll talk about that in a minute. Where's my health pathway? Oh, there it is. Okay, so sexy drugs. Elon Musk has sadly made these drugs famous. So the GLP-1 receptor antagonists were designed for diabetes, but the side effect was they cause a lot of weight loss. So they have now become the new sexy worldwide drug for all things metabolic. So they're not approved or funded for use in metabolic liver disease at the moment. They're approved for obesity and type 2 diabetes, but they have been shown already to reverse steatohepatitis, reduce cardiovascular risk, and that it's safe to use across the spectrum of metabolic liver disease with or without fibrosis. The problem with this drug is it's currently around $20,000 a year. And so what I saw when I was working in the UK, so they've been using these drugs for a long time. They have several generations of these drugs in use. What I saw is that people were not changing how they ate and relying on these medications. They would lose 10 or 20 kilos, and then the effect of the medicine would wear off, and then they would need the next generation of medications. So what's happening is that the government was essentially hooked into spending, say, $20,000 a year continuously for these patients, because there was no intervention given to these patients about how they should eat. So they needed these medications to maintain any ongoing weight loss. What I would love to see in New Zealand is that if this gets approved in the future for us to use for weight loss and metabolic liver disease, that we use it for a period of time to achieve a goal, and that we combine it with these nutritional interventions so that we can educate people around how to change their eating. Otherwise, the financial burden on the health service is going to be significant. So this is our health pathways, very exciting. So if you see a fatty liver on ultrasound, or you have an elevated ALT or AST on 2 readings 3 months apart and not improving after you say tried to stop medications, and you've ruled out other causes of liver dysfunction, and patients have risk factors such as diabetes, obesity, or cardiometabolic risk factors, then do a FIB4 using your Med-Calc. Remember to get an AST. And then just look at our guidelines. Essentially, if they're less than 1.3, if they're less than 60 or less than 2, if they're over 60, then they don't need to come. And you can follow what we've just discussed. If they've got a higher score, then they'll need to come and have a fibro scan and be triaged, whether they need to stay under us or whether they'll go back to primary care, again with close monitoring, and then coming back for further fibro scans. Thank you, everybody. I'm very excited to hear your questions.
Nice case, Hannah, that was very good. So I guess the question for us as GPs, we get the blood tests which show fatty liver, and as you say, I have a silent groan to myself.
Yep.
Having done it, because the patient's BMI is 30, so I'm not surprised. So, and ultrasounds are really difficult for us to get in some practices unless patients.
Interesting. Okay.
The budgets, I'm pretty sure I'm speaking for all the troops here. So what would you suggest? Repeat it if it's staying stable, then just check it occasionally, or if it's not going up, what would, I guess my question is, what would be concerning, even in the lack of an ultrasound?
What you mean? What level of liver test would be concerning?
When should we start to sort of push for the ultrasound and more investigations or referral, I guess?
I think I will often write dubious referrals for ultrasounds, because I've seen so many liver lesions with minimally elevated or unelevated liver function tests, and metabolic liver disease is known to have HCC even without cirrhosis. So I would push for an ultrasound personally, and I guess if it's declined, then I guess the onus is on the person that's declined it. But you know, all the incidentally found liver lesions are found in primary care. And, we do have young people coming in with HCCs and cholangiocarcinomas and big adenomas and things. And I guess it's that ultrasound that was done for mildly elevated liver tests that finds them. So, and obviously stones, which something can be done about stones, something can be done about liver lesions. And I guess that's what you want to look for.
Question here from Sally. Can you talk about the hepatocellular cancer risk of NAFLD?
Well, I don't know if I can give you a number for the non-cirrhotics, but it's obviously in cirrhotics it's very high. So alcohol, NAFLD, and Hep B would be our entire HCC meeting.
So what was that? Alcohol,
NAFLD, and Hep B.
Okay.
Yeah. Very rare to get HCC in autoimmune hepatitis or PSC and things like that. The non-cirrhotics, we get some non-cirrhotic HCCs every week, but it's hard to give you a risk, and it's certainly, the risk is not high enough that anyone does a screening program at the moment. And the other problem is that obviously they're not necessarily AFP positive as opposed to hepatitis B. So again, doing an AFP is not necessarily helpful in these cases. So, I don't do ultrasound screening for non-cirrhotic fatty liver. I think there is actually a sexy test that's being investigated now by Professor Gain that is AFP plus a new marker, which is supposed to be much more sensitive. So I suspect that in the future will actually become the new screening tool in primary care.
So how do we manage high ALP?
ALP is quite different. So ALP is either bones or bile ducts. So that's what you need to think about. So if it's an isolated elevated ALP and it's mild, I normally check vitamin D first. That would be probably the most common cause. And other things, obviously, you'd be thinking is PBC or some other biliary issue. So I'd be checking autoimmune markers, particularly for AMA. For PBC, I'd be wanting an ultrasound scan to check for any other biliary issue like a cholangiocarcinoma or cholangiopathy. And thinking about bones, do they have any bony pains? Do I need to look for bony lesions? But hopefully it'll just be vitamin D deficiency.
Talking about a gastric bypass, where does that fit in with this?
My feeling on that, actually, a patient asked about this recently, and my feeling is to wait. Actually, at the moment, I feel like we're in this period where these amazing drugs are actually coming. So if you've looked after, and I'm sure you will have patients who are post-bariatric surgery, they're not happy people. They have often lifelong symptoms as a result of that surgery. So the real Ys have their malabsorption, the sleeves have their reflux, and they get some weight loss, but usually it plateaus. And there's potentially lifelong complications. So I would say, with the fact that these drugs are going to come in, and probably I might get shot by the surgeons, but it might completely negate the need for bariatric surgery. That's my opinion, and I think that they're going to be funded very soon. So I would say, unless they're absolutely desperate, hold off. And also send them to a dietitian. If you don't feel comfortable to do the healthy plate model with them, it's worth them going to spend a few $100s to go and see a dietitian who is passionate about this subject to try to help them.
Another question on drugs here. What is the current recommendation or advice for using Duramine? So we get a lot of patients pushing for Duramine because it's relatively cheap. What's your view on that?
They tend to elevate your liver test quite a bit, Duramine. Again, you can try it, but I think the main thing is they have to change how they're eating, because all these other things are just a band-aid. Because you'll take your Duramine for 3 months, you might get some partial weight loss, but if they're still drinking 2 liters of Coca-Cola, you're never going to make a difference. And again, it can often take several appointments to get that through to them. Like the first time you meet them, you might be able to get them to stop eating pies. The second time you might get them to, stop eating chocolate every day. And then, it's kind of, it takes time to really get through to them, but they will see the benefits if you kind of keep working at it. And I really think that we did not get taught this at medical school. And I just don't think that we actually get taught on how to do a diet history and how to really educate people and teach them about eating. And I think it's a really big gap in our knowledge and practice.
Actually, the webinar we did a couple of weeks ago was from Dr. David Unwin from Liverpool, who was talking about low carb diet. Low carb diet. He published in the BMJ 150 patients who he managed to get off diabetes drugs and got rid of it.
Well, this is low carb. So this is essentially high fiber, lean protein, and low carbohydrates. It's not the same as keto, because again, keto is kind of a temporary thing. You can't do keto forever. And keto, you eat too much meat and it's a bit unhealthy. But this is essentially learning how to control the carbohydrates to control your weight.
So you mentioned about what, statins making fatty liver worse, but statins can raise your ALT anyway, can't they?
So statins don't cause steatosis, but they will often elevate your liver tests a bit. So I think if you have problems with atorvastatin or simvastatin, then wait, let the liver test get better, and then try things like pravastatin or rosuvastatin, and just start low and go slow. And I guess the thing is, if you put it on and you have a mild elevation in your liver test, I guess the question is, does it really matter?
Yeah.
Probably not. If the ALT is, say, less than 70 and the GGT is kind of less than 200, you could probably tolerate it if you think that, if they have a cholesterol of 7, you've got to balance the risks, haven't you?
It says here you can have fatty liver with normal liver functions.
Oh, totally. Yep.
Okay. How long does it take to remove the fat from the liver?
Good question. Oh, it's going to be months to years. I think the liver tests will normalize before you get all the fat out. If a patient can afford it, then they can pay for. So a FibroScan gives you a fat reading. And so the CAP on FibroScans is really good. I think it's only about $150 or something for a FibroScan. So they can get a CAP, they can get that done every year or so, and then that gives them kind of something to aim for, essentially.
Can they be done in the private system, FibroScans?
Yeah, we have them at McMurray's. I'm sure most places have them.
Andrew's got a question. Is checking monitoring ferritin of any value in assessing MASLD?
It's normally due to alcohol, in my experience. Elevated ferritin, inflammation, or alcohol. I think it would be, or a drug-induced liver injury. I'd say it would be really primarily due to MASLD, in my experience.
If you determine statin as the cause, what do you recommend then if the cholesterol is dangerously high?
Yeah, so as we discussed, so obviously they can try things like fish oil, though we know the fish oil quality is not great. So just stop the statin, let the liver test get better, and then try pravastatin or rosuvastatin at a low dose, and just monitor, and then just try to increase the dose cautiously.
Another option in primary care might be azeptamide. I don't know if that
yes.
It's not as good in my experience, but I guess it's better than nothing. Well, not even the cardiologist can do much better, really. There's a limited choice of drugs, isn't there? What age can you use for in children and young people?
Good question. I assume you can. Yeah, maybe. I assume so. I haven't tried.
Politics and political lobbying here, the role of government in forming policy about ultra-processed foods. Any thoughts?
Yeah, I've got some thoughts. I think I'm really keen to see educational reform around this. So I think we need to start with the schools. In terms of, I'm not sure in terms of government policies, but I think that recommendations should be put out and we should be more clear. So that when you have in your practice, cut down on alcohol, stop smoking, we should be advertising, eat a whole food diet. stop eating processed foods. You know, these messages need to get out there. And I think we need to be teaching the healthy plate model in schools again and again and again, you know, banning all processed foods in schools, you know, no packets, no fizzy drinks, no, because I know that in my daughter's school, which they have this rule, they're not supposed to have it, all her friends eat exclusively from packets. And my daughter said, "No, it's not fair. I'm the only one that doesn't have packet food." And I said, "Well, you're lucky then." So I think that I'm very excited to hear from anyone who is keen to take on kind of government or educational people about how we actually really get this strong message out there. I can imagine it'll be extremely unpopular commercially, because obviously, you know, there's a massive food industry that is built around processed foods. But, you know, it is the root cause of the majority of health problems we have in New Zealand. So
patients have isolated low-level GGT. In Southern, we can get an ultrasound if only the GGT is involved. Is Southern correct to consider this particular enzyme is not of concern, provided excess alcohol excluded? I'm not sure.
So what are they saying, that if only the GGT is elevated, you can't get an ultrasound? Is that what they're saying?
Yeah, if only the GGT is involved, yeah.
If you want to be finicky, then if you're looking for gallstones, it should be the ALP and the GGT. But I mean, I think I think they're being a bit difficult there.
Yeah, it differs from PHOs to PHO still, to say they've got quite different health pathways depending on where you live. If a patient has a fatty liver on ultrasound and needs to be started on statins with a high cardiovascular risk assessment, which statin would you start, and when would you repeat the blood test to check the liver function?
Well, if the liver tests have started off normal, then I would just go with your standard, but then I would check your blood test in maybe 4 weeks.
If elevated transaminases return to normal on withdrawal of statin, do you re-challenge with statin again, the same statin or a different one?
Different one only, not the same.
Okay. The same thing will just happen, will it?
Yeah, basically. I mean, unless you try for a lower dose.
This is a question about ferritin. So often I see a mild ALT, e.g. 60, BMI 35, ferritin raised 400, low iron SATs, doesn't buy me an ultrasound on health pathways. Your comment on the ferritin? Would you be worried about a ferritin at that level?
No, I'd still be thinking alcohol.
Right.
That's the primary cause of an elevated ferritin in my clinics is alcohol.
What about heterozygotes for the hemochromatosis gene?
Yeah, if the saturation is low, then it's not hemochromatosis.
Yeah. What about focal nodular hyperplasia? Should we stop estrogen?
It depends. Well, if estrogen's driving it and they're developing portal hypertension, then yes. If it was from a different liver injury, yeah, no. I mean, it's difficult. Estrogens are very difficult. If it's growing and it's a significant size, then I think essentially you often need to change to progesterone only.
Okay. How do we manage liver changes secondary to Epstein-Barr virus?
So if you've got, well, EBV can take a really long time to settle. If you're confident that it's EBV, it's supportive cares, obviously. So things you can do to try and speed it up is essentially just give them nutritional supplements if patients are quite unwell. So I just give them some Ensure or Fortisip if they're struggling to eat. That kind of helps the liver regeneration. Obviously, I just do regular blood tests. I might give them Vitadec, which is fat-soluble vitamin replacement, because if they're jaundiced, they'll be malabsorbing fat-soluble vitamins. If they have bad steatorrhea, I might give them things like Creon because their pancreatic enzymes don't activate properly. Sometimes cholestyramine will help with itching and the steatorrhea as well. So if you know it's EBV, you really just have to wait. I've had patients that have been sick for 3 months with a really severe bout of EBV. And obviously, if there's any uncertainty, you know, then they can be referred in. And I actually biopsied someone recently because his ALT was still kind of 400 and he had a bilirubin of over 200 and he wasn't settling, but it was all EBV and he settled eventually. So it's really just kind of supportive
That leads on to a question: how high should liver enzymes be before we talk about acute hepatitis?
I probably want an AST ALT of 200, I would say, to be thinking it's something significant.
Each one of those.
One or the other,
Yeah,
or both.
okay. Any role for starting a GLP-1 in the patient you discussed?
Well, he's already improving, so I think he's going to make it. I think other patients who are starting from a higher baseline, 150, 200 kilos, that might be nice to give them a head start of a 20-kilo weight loss with a GLP-1 antagonist. But I think this gentleman's intelligent. He works for Ministry of Defense. He's already tried to change his diet. I knew he's going to listen. He's already improved almost normalized his liver tests. And so I think he would be okay. But I think, yes, in the future, there will definitely be a role for GLP-1 antagonists. I just want to be really cautious that it doesn't take the onus off the patient to change how they're eating. It's not a free ride.
What online resources do you recommend for your clients to read dietary changes?
I usually tell them to Google high fiber, low carb diet. So that normally comes up with lots of things and then gives them lots of different ideas.
Neil, from Nelson region, what evidence is there for weight loss advice and with behavior change?
Yeah, so I guess there was that kind of composite study that looked at 22 intervention studies that used this plate model. But I think that's probably the only thing that showed a difference. I mean, so I guess there's lots of different diets. I think the historical problem in the past has been that diets have been very restrictive. There's been these kind of very calorie restricted type diets that I think actually are just not sustainable. So people get temporary weight loss, but then when they go back then they don't get education about how to eat normally. So when they finish their, 3 to 6 months of doing this, very low calorie diet, then they just go back to their normal diet. I think that's essentially the problem with dieting, is it's not sustainable. I do think this whole healthy plate model actually works, and I think it can actually work in the long term. And I think if we all, as healthcare professionals, get on board with it and we all start singing from the same hymn book, then I think people will actually get the message, because then we'll be following people up every time we see them and keep bringing them back and just reminding them, no, actually, you can't get away with eating that. I remember one of my patients telling me, I've been eating a packet of chocolate biscuits my whole life, and I think I'm getting away with it. And I said, I really don't think you are, actually.
Based on what? Based on liver function or?
I had decompensated liver disease and multifocal cancer from metabolic liver disease. So he really wasn't getting away with it. Yeah.
You mentioned NASH and NAFLD and MASH and MAFLD. The NASH MASH is the more extreme form, is that right?
So the NASH MASH is the inflamed form that tends to be more aggressive in how it progresses. But yeah, I mean, they're kind of all variants of the same thing, really.
What is your experience of Contrave in terms of weight loss? That's the bupropion naltrexone combination.
I haven't used that, I have to say.
What is the risk of weight loss drugs we currently use in New Zealand causing more liver function derangement?
I guess, I'd say you guys are using them more than I do. So, I mean, naltrexone, I've used that before in other contexts. I haven't had any problems with that. The Duramine, I have had problems with Duramine. GLP-1 antagonists don't cause problems. What other drugs are you guys using?
Probably Saxenda, Duramine,
Mm-hmm.
and Trulicity, dulaglutide. Well, that's not available at the moment.
I think there is some tolerance issues with Saxenda and Trulicity, but I haven't been giving them myself, so I don't know the details. But there are some issues with them, but I don't know the specifics.
Emma asked about practical advice about exercise. I have a little narrative about exercise, is that your muscles are factories, endocrine factories is the thing, create hope chemicals in your mind when you exercise. And then I say to my patients, would you like some hope chemicals? It's a winning line, I tell you. So Emma, try that one, hope chemical.
Yeah. So in terms of fixing things, I tell people that it's 95% diet. So your weight is 95% diet and 5% exercise. Exercise comes and goes. So unless you're going to be an elite athlete, I think the problem is if that people find doing exercise, taking up exercise regularly is quite intimidating. So I say if you can just start walking, just do anything, whatever you like, walking, cycling, swimming, doesn't matter what you do, but just start with 20 minutes a few times a week. And if you can build it up to more than that, that's fantastic. But the most important thing is what you eat.
I think that 95% is in what you eat is a good way. Tanner Fishman used to say, if you want to lose weight by exercising, you have to walk to Hamilton and back each day. Which I thought
Yeah, exactly.
It sort of it makes people come back to the food, hopefully. What about the carnivore diet?
So that's keto. So lots of people use keto. It's very popular amongst bodybuilders and sports people. I would just be concerned in our group of patients, the risk of worsening cardiovascular disease. So I think consuming that much meat is not safe. So I, as a practitioner, would never want to recommend that.
Okay. The use of metformin in AFLD?
No, we don't. I mean, if they have diabetes, we use it, but I don't think it does much, unfortunately, to the fatty liver.
Any comments about caffeine consumption?
Well, I'm a big promoter of caffeine. I think that published evidence that caffeine is good for your liver. I'm not sure about fatty liver, but I think, coffee, obviously you have to think about what milk and sugar goes into it. But I think the coffee component itself, within reason, 2 or 3 cups a day is no harm. But you always have to ask about sugar. I had one patient having 20 cups of tea, each with 2 teaspoons of sugar. So don't forget to ask about the sugar.
Is an isolated GGT enough to look for steatosis?
Yes. Yes, I think so. It definitely can be steatosis. Medications or steatosis would be my choice for an isolated elevation in GGT.
Yeah, and also alcohol, I guess, is the other one, isn't it? So
yeah.
On a population base, how do we support healthy weight?
It's education. We just have we as health professionals need to take up the mantle that we are against processed foods, that we actually, we should be talking about going back to whole foods diets, away from processed foods, and that we should be talking about proportions. I think this needs to be taught in schools. I think we need to be talking about it to all of our patients. We as a group of people need to start all singing from the same song sheet if we're going to help support people with their weight, because all we're doing, and we do the same thing, patients come in and then you give them a whole bunch of drugs and the patient leaves. And it's like, tick, 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 I've done my job. But actually, we've not tried to fix that patient. So I think it's trying to change how we look at that situation. And instead of seeing it as hopeless, oh, this patient's overweight, this is hopeless, I can't do anything. Take that rhetoric out of your mind. I think that this is actually your opportunity to fix someone. My greatest satisfaction in my job is either getting someone to stop drinking or getting someone to lose weight. Because those are the only times that I fix people. And when we transplant people, that's a failure. In these fatty liver and alcohol patients, we've failed. So you guys all have the opportunity to fix people.
There's one little trick I've found helpful of late with the drinking is to say to people, it fragments your sleep. And people are more sleep. We're pretty obsessed about having a good night's sleep. And I don't think people make the connection. And it's remarkable when people reduce alcohol, how things like their mood and whole demeanor, like within weeks, basically.
Oh, totally. They say I'm sad. I drink because I'm sad, but actually they're sad because they drink. And I need to drink to sleep, but actually 4 to 6 weeks after you stop drinking, you'll be sleeping better. So
if you have fatty liver with normal LFTs, what are the symptoms to look for and what abnormal tests are likely to be found?
I guess if you have fatty liver with normal liver tests, it's going to be hard, but they presumably will have other metabolic conditions that you'll pick up and you can follow the same pathway. I guess if you see fatty liver on ultrasound scan, you can still do a FIB4 if they have risk factors.
So FIB4 is a good idea to do.
Yeah.
Low ALP, is that an issue?
Low ALP, no.
Okay, how could you explain in layman's terms what fatty liver, MASLD, is for patients? How do you perhaps explain it to somebody who's not super health literate.
So what I say is, so when you say you eat your bowl of, rice and pork, and then that's all broken down into sugar. The sugar goes into your blood, and then you get a big high sugar. And then what happens is your body grabs all that sugar because it doesn't like to have that high sugar, and it puts it all into your liver as fat. That's how you get fatty liver. So that kind of gives them that direct correlation between what they eat and what's in their liver. And then I explained that as you change how you eat and you don't get big spikes in blood sugar and you lose weight, your body will actually take that fat out of your liver. But while it's in your liver, it causes inflammation, it makes your liver unhappy, and that's how you can get scarring and problems.
Dr. Unwin, he sometimes uses, he has diabetes, he puts on one of those Libra pads and then he sees what happens to his blood sugars. It's an expensive way to find out, but I think it would shock us all if we did that, actually.
Yes, it would.
Study in old Greek study that statins are actually beneficial in reducing progression to liver fibrosis. Is that?
I think, yeah, statins are effective. They are effective, but they're not. Yeah, they're not. They help a little bit, not a lot. So unfortunately, they're not going to stop you developing cirrhosis.
Okay, so here's a question from Anne. So do I hear correctly that sustained liver function tests is to be investigated even if they less than 3 times normal range, which what used to be taught?
I think if, like this gentleman, he had a mildly elevated GGT and a mildly elevated ALT with other metabolic risk factors, I think definitely you should do your FIB4 and go down that whole pathway. So I think I guess it's just the guidelines are trying to stop them being referred to the hospital. That's what the guidelines are for. But it's not necessarily the right thing for the patient, I guess.
Do you find a lot of people don't know how to cook with whole foods?
Yes. Yeah. But I think it's not as bad here as the UK. The UK is atrocious. They have just turned into the microwave meal country. They're just terrible. So I don't think we're quite as bad as there, but we are heading in that direction. And I think people need to relearn. I think it was very difficult last year when vegetables and things were so expensive, but the price has come down a bit. So that's better.
People are liking the fact you're talking about prevention, education, and changing lifestyles. So you're getting lots of good feedback here, Hannah. How long does ANA stay positive following normalizing of LFT? So that ANA probably was a bit of a distraction, would you say, in that?
Oh, the ANA was nothing. It's probably a false positive. Lots of people listening might have a positive ANA.
Yeah, it's not a test I do anymore because of that.
Yeah.
Is Hep C involved? At last place I worked, we got all our scans when screening for this.
I mean, all patients with mildly elevated liver tests, I'm sure you would check your viral hepatitis screen as standard. Yeah. His was negative.
What level of ASP raise would you consider bone marrow pathology?
Oh, ALP.
Yep.
Well, I guess if you've checked your vitamin G and you've checked for PBC and you've done an ultrasound scan to check for your bile ducts and you still have an elevated ALP, then I'd probably be worried about something going on in the bones. But if they have bony pain anywhere, obviously you can get an X-ray to look for lesions.
Is there a role for using aziptamide or bezafibrate for MAFLD? They're both lipid-lowering drugs.
So bezafibrate, I don't think we use it for MASA. We use it a lot in cholestasis. Bezafibrate's now emerging as one of the primary treatments for itching in PSC and PBC, and I've actually recently used it off-label in obstetric cholestasis as well. It's amazing, but I don't think that there's any evidence for it changing outcomes in metabolic liver disease.
Okay.
But I mean, obviously it's safe for cholesterol if you're going to use it for cholesterol.
Question here about menopausal replacement therapy. Is transdermal estrogen safe as it bypasses the liver?
I mean, I guess what are you concerned about? If you're concerned about, liver lesions or worsening fatty liver, again, just need to balance it really against, what the patient needs. So I guess it's not dangerous. I think if the patient had cirrhosis, I'd be more worried about developing HCC. But if they didn't have cirrhosis, I would probably just give it and monitor their liver tests and, try to keep working with them if they are overweight and they have metabolic risk factors, just keep trying to optimize that to hopefully balance out the effects of the estrogen.
Okay, you might have to explain the next two acronyms, but marginally raised SMAs, how
Yeah.
like IAH, what are they? You better spell them out.
So smooth muscle antibody is the least useful for AIH. So it is positive in a lot of AIH type 1s, but you also get a lot of false positives. So the ones that are useful, so an AMA, that's very likely to be PBC in the context of elevated ALP. LKM, which you probably are not requesting, is very specific. But actually SMA and ANA are very non-specific. And so obviously in the context of significantly elevated liver tests, if you have that, you might be thinking about autoimmune hepatitis. But if they're mildly elevated, then it's probably not.
Any comment on lipidemia management? Is there a place for Ozempic, Saxenda, Ozempic being semaglutide?
I've not used it directly for lipids. So I know that that's used in private practice for weight loss. I assume if you lose weight, lipids will come down, but I don't know about the direct impact on lipids from that.
Very interesting stuff on the semaglutide and heart failure. Actually, the weight loss makes quite a difference to cardiologists are going to get. I think everyone's going to get excited about them when the semaglutide comes here. Okay. So your patient was on dual ARB, losartan and candesartan. Any reason for that at all? Seemed a bit of an odd. I wondered that myself.
Yes. No, I don't know. It was prescribed by his GP. I'm innocent. I don't know.
Not much point in doing two, really.
No, that's true.
Okay. MOH and WHO guidelines recommend a plant-centered based diet, including plant proteins, not just animal sources, protein sources. Hugely benefits environmental concerns. Do you recommend this?
So I think plant-based is actually a little bit more tricky in a few ways. So if you think about the plant sources of protein, they often contain a high amount of carbohydrates. So lentils and beans, for example, contain between 40 to 60% carbohydrates. So this is when I talked about knowing the culture that you're talking about and the food that you're talking about, these are the kind of things that you need to understand. So when you're talking to people from an Indian background, for example, and you know that maybe they're a vegetarian and they're eating potentially lentils most of the time, then you need to think about that when you're talking about the rice portions, because actually they can, or are they having roti and rice? They can only have one, and how much can they have? Because there's a lot of carbs in their lentils. So, I think in terms of whether people eat, the other issues as well are food allergies and intolerances. So apart from the whole food, so lentils and beans, I guess they are whole foods, but then a lot of the other plant-based foods are highly processed. So I think, the fake meats, for example, are one of the most processed items in a supermarket. So having tried them myself and felt extremely ill eating it, I'm not sure that it's something that I would definitely recommend. So certainly, reducing your meat, like for example, you do not need to eat meat several times a day. You do not need to eat it every day. But I think, so I met quite a few patients in England who went to a plant-based diet, but then actually were eating zero protein. So they were basically eating no protein at all and becoming very weak and lethargic and actually becoming bedbound. So we need to be very careful when we're recommending these plant-based diets, that we're actually giving information about how they need to get their macronutrients and that we're not replacing it for ultra-processed foods. So again, it's quite political, but then I guess, I'm certainly not going to be forcing everyone to go fully plant-based, because it's quite complicated and it's got positives and negatives.
On direct questioning, quite a few patients are on herbal meds when LFTs are abnormal. Any particular herbal medications we need to be aware of?
All of them. Stop them all. That's what hepatologists do. We stop them all. So, Yeah, I've had patients die from liver injuries from herbal medications. We've transplanted patients from liver injuries from herbal medications. And, what I would do is I stop all of them, get the liver test to be normal. And if the patient desperately wants to be back on them, then they have to restart one at a time. And then they have to have the liver test at kind of 6 weeks back on that medication for 6 weeks to prove to me that that medicine is safe.
Well, also, I think with some of the offshore brands can have things added in them, haven't they? Like prednisone and various bits.
Yeah. Oh, yeah, exactly. You have to be so careful. And, they just don't have the same safety requirements, and they make all sorts of claims. The one that killed a patient in England, I Googled it, and the first thing they came up with was 100% safe. So
that was a fantastic talk, Hannah, and I'd just like to thank you for putting this on. It's lovely to have all your expertise, and on behalf of the Goodfellow Unit, thank you very much.
Thank you so much for having me.